All right, welcome back to the channel. Sam Visnick here, Release Muscle Therapy. In this video, I'm going to walk you through some simple self-assessments that you can do to assess the psoas and of course the associated hip flexor muscles. Now before we dive in, it's important to understand that there's no single test, range of motion assessment, etc. that's going to give you all of the information that you need in order to determine what might be going on with you. For example, we're going to be testing the psoas muscle, but it's not going to give us information about what might be happening inside of the joint. We know which way it might want to go, preferentially, etc. But of course, if there's something going on, as I've expressed in other videos on my channel, for example, with underlying hip pathology, then those things need to be ruled out, usually with visual imaging through your medical doctor, etc. So these are just tests. They can give you useful information and provide a direction on, for example, what stretches might be useful, what types of exercises, etc. But just take that into consideration before we move on to the next steps. All right, so before we dive into the test, let's talk about the psoas real quick and what it does so you understand why these assessments make sense. The psoas muscle connects to all 5 lumbar vertebrae. So all of these guys right here, slightly off to the side. And if you look at the angle moves slightly at an oblique or an outward angle and attaches on the inside of the thigh near the groin area. The primary function of the psoas muscle is to flex the hip, so it brings that end point right there up toward the vertebrae. So it brings your knee up toward your chest. Now, considering that slight angle there, it may contribute to a little tiny bit of rotation, but I think a lot of people might be getting carried away with how much rotation it contributes to. So we're going to look at which way the hip tends to go, but the primary thing that we're looking at is the ability of the psoas muscle to lengthen as we extend the hip, and that's what we're looking for when we do our tests. Now the other muscles going to be associated here are going to be the rectus femoris. Now the rectus femoris is one of your thigh muscles or your quadricep muscles. Now quadricep means 4. 3 of those muscles predominantly are just starting on the thigh bone itself and connecting down into the knee. The rectus femoris, however, goes down to the knee but goes up to the hip. It attaches on the front side of the pelvis. So the other quadricep muscles do not act on the hip itself. The rectus femoris does. So there is one quadricep muscle that does that. Oftentimes during hip flexor assessments, this muscle is not identified relative to the psoas. So anytime any hip flexor test seems to be positive in terms of tightness, almost always people say it's the psoas. Yeah, but it could be the rectus femoris, so it's important to note that. One of the other hip flexors that we need to look out for is the TFL, that's the tensor fascia latae. It's a small muscle here just off to the side of the hip, like at a 45-degree angle. It does connect into the iliotibial band, so we'll be looking at that as we're doing our evaluation as well. The last hip flexor is the sartorius. The sartorius is the longest muscle of the body. It is on the inside of the thigh and it does wrap around to the front of the pelvis here. So it is a hip flexor muscle, although we rarely find that that muscle is actually shortened and tight. But again, it is something to take into consideration as we're doing these tests. So that's just a quick rundown of the anatomy. If you need more information, I do have additional videos on my site about this, so be sure to check those out. But now let's dive into the tests. All right, so this first test is called the Thomas test. It's done laying on your back. It is a very easy test to perform, and it will be obvious if the hip flexors are tight, so you really can't miss this one. So what we're gonna do is lay down on the back here with the legs straight out. Now, first and foremost, one of the features is when people have shortness in the hip flexors, there usually is some lower back discomfort when laying with the legs straight out, especially over a period of time. So I always ask that question during evaluations. But to assess the psoas, what we're going to do is with our legs just straight out, we're going to bring one knee up to the chest. Now, as we bring that knee up to the chest, the outcome is to actually flatten the back. So as we bring that knee up and we flatten the lower back, the pelvis is going to start rotating backward. When that happens, if there is shortness in the psoas muscle, this opposite leg will start to pull up off of the table, okay? So if I bring that up here, you see on my leg there is no movement here, okay? Because my hip flexor length is actually too much. I've got excessive length in my hip flexors. So when I pull mine up here, there's not much happening here at all. However, if you start to bring your knee up toward your chest and this leg starts coming up like this off the table, okay, so the thigh is starting to rise, that is from a contracture or a shortness in the psoas muscle. Okay, so this is a very, very easy test. If you bring that leg up and that pops up, there's your positive test for the psoas. Now, in my practice, very rarely do I see this test positive, okay? Meaning that most people's leg isn't going to lift up like this. But what will happen as the leg lifts up just like this is this leg will start to rotate or spill out to the side. So if that happens, oftentimes we're going to start looking at that lateral side, which is the TFL IT band, okay? So there is one thing that we're predominantly looking for is that knee going up. If that is not present, are we noticing the leg starting to spill out to the side? So there are two important findings to look at in this test. Okay, so let's take a look at the next test. While the previous one works on assessing just predominantly the psoas, when you pull your knee up to your chest, we're not getting a lot of information about the other hip flexors, in particular the rectus femoris muscle. The rectus femoris muscle needs to have a knee bend in order to get a quality evaluation on it. So what we're going to do is we're going to find something that will allow us to lay down and the leg descend over something. This is probably the most challenging thing that people have an issue with, is finding access to something to be able to do this test with. A massage table or a therapy table is usually the best option, but sometimes if you have a bed that's high enough, or if you're of a certain height, you might be able to get away with that. If you're taller like me, at 6'3", it's much harder to do this on a bed because my foot may hit the ground before I get a good assessment. So having a correct height is kind of important in this test, all right? So what we're gonna do is we're gonna sit toward the edge of the table, enough that my butt bones are actually on the edge of the table, but not enough where I'm gonna fall and cause injury, so be cautious of that. But I'm gonna sit toward the edge, and then what I'm gonna do, and for this test, I'm gonna pull my left leg up so you can see what's going on. I pull my knee up, and the outcome is exactly the same as what we found with the previous test, which is we want to keep that lower back flat so we can evaluate the opposite leg. So I'm going to roll my way back. I'm going to bring both legs with me, but I'm really holding on to the left one. So as I lay back and I pull my left leg up to feel my pelvis rocking backwards so that my lower back is flat, now my goal is to actually lower this leg down. So I let it descend. I'm going to go ahead and watch myself do this here. And as it descends and it hangs fully down, while keeping this left knee pulled up, what is the position of the thigh bone? So if in the previous test we found that the psoas was not shortened, we should see pretty much the same thing here. We should see the thigh bone is roughly parallel to the level of the table. Now oftentimes if there's a little bit of shortness or tension here, that we have to cue ourselves, oh, let go or relax, so we can really get a true evaluation of this. Now obviously this is difficult to look at yourself. If you have a mirror next to you, that's helpful, or someone else taking a picture, it could be pretty useful to do the self-evaluation in that way. But as we lower the leg down, we should see that the thigh is parallel with the level of the table, ideally maybe even a slightly angle downward, okay, so about -5 degrees or so. Now what we're going to be looking at additionally is the knee. Now in the textbooks, we generally see that optimal quadricep length in the rectus femoris is that we're seeing a 90-degree angle in the knee so that the shin is hanging completely vertical, so up and down. It's pretty rare to find that most people will have a test that looks like this, especially if they're an athlete or somebody who works out regularly, especially the quads. We'll usually see something like this where the leg is out a little bit. This is pretty acceptable range of motion in my opinion. It's not too much to be concerned about. However, when we start to see something like this and the leg cannot, even when the person tries to relax it, it cannot go any more than this, then that is going to be indicative of a shortened rectus femoris muscle, okay? So we're looking at how far that thigh bone descends, but also the knee angle is going to give us a good evaluation of what's going on with the rectus femoris. Now there's one more thing that you should be looking at here, okay, which is helpful, that I do anyway, is which direction does the leg go? So we talked about in the previous test, if the psoas is short, okay, the leg won't descend, but it can go down, and if we pull the leg up, that causes this leg to just flop out to the side. This is commonly, generally evaluated as shortness in the TFL and the IT band, right? And you should see generally the same kind of pattern in this position, but it'll be much more obvious. So as this leg descends down, does it really drop out to the side? Now again, It's normal as the leg goes down to have a little bit of abduction and external rotation. That's where it starts to rotate out. But if you're seeing this flopping all the way out to the side and it's kind of hanging in midair, again, that's a positive sign that we need to look at that TFL and that IT band, which I'll show you here in a minute. But the opposite can actually occur. So as someone descends down, the leg may move into the midline and it might rotate in. This is very common with people that sat like a W when they were a kid, and there's a lot of laxity there that allows that hip to rotate in quite a bit. So when I find that, that is an additional thing that we need to look at to see that there is resistance to moving that leg outward and rotating it out, okay? So not only are we looking at the ability of that leg to go down and the quadricep, but we're also looking at how much movement we're seeing in and out with that abduction. So there's a few very valuable things that we can look at throughout the course of this testing procedure. When you're done, to get up safely, I usually hold on there. You can hold on to the table and then walk your way back up again. Now, if you have positive findings during the Psoas test, meaning the psoas itself is tight, also if the rectus femoris is shown to be tight, then the testing position itself can be a great stretch to do if you have access to it. And a lot of people comment that it is a great position for them because they'd never really felt the hip flexor stretch in any other positions, oftentimes because that requires you to have a lot more control of the pelvis in order to standardize the position of the low back and so forth and get that stretch. In that Thomas test position with the leg hanging over the table, it's pretty easy to just let gravity do the work for you, and it's a great position to not only assess, but also to stretch those muscles to encourage optimal range of motion. Now, if the rectus femoris was found to be tight, you can use that Thomas test stretch position, but also we can directly stretch the rectus femoris with a very simple standing quadricep stretch. So if I just hold on to something, it could be a chair or whatever it is, grab onto my leg behind me, I'm going to be lengthening that rectus femoris. But oftentimes we see that there are a couple of issues in order to clean this up. Number one, if I just grab my foot behind me and I try to pull my heel up toward my rear end, if I'm getting a stretch, then that's good enough. You can start there. But since the rectus femoris acts on the hip as a hip flexor, we do need to be a little mindful of the position of the hip in order to maximize this stretch, especially if you're not getting much of a stretch just doing this. So what I try to do in this position is start to pull my heel up toward my rear end to a reasonable degree, and then what I'm going to do is I'm going to tuck my pelvis. I'm going to do a posterior pelvic tilt. So in this position, if I tuck my tail and I squeeze my glutes together, that is going to start to extend the hip, and it's going to basically lengthen this section right here on the front of the hip. There's going to be a greater influence on stretching that rectus femoris if I tuck my tail, okay? So doing a simple standing quadricep stretch with a little bit of a tail tuck can really work to emphasize that rectus femoris muscle. After we stretch that for a few rounds, it could be 2 to 3 repetitions for that standard 30 seconds, then we can go back and test that Thomas test position and see if that leg is hanging a little bit more vertically, the shin is, and that would indicate that the rectus femoris stretching would be positive, have a good impact on that test. All right, now since I brought it up and I'm going to get a lot of questions about this, I do want to talk about what happens and how to further assess as that leg is starting to drop down. Why does it go all the way out and rotate outward, which is called abduction and external rotation? Now again, to some degree this is completely normal. So however, if it's really veering out there to the side and we're noticing a lot of tension problems in the hip flexors, this is the next area to look at. Now I'm going to warn you, it's quite complicated because this is an area that a lot of practitioners struggle with, is trying to understand and put this all together, but I didn't want to bring it up without at least leading you in the right direction. Now I am going to post a video on this below that I talk about this test, especially in particular and in depth about what is actually happening and what we're looking for, but ultimately we're just looking for the TFL, the IT band, and also the ability of the hip to actually adduct, to be able to move down in the socket. Now this really needs to be done by a practitioner to have good, accurate results, but you can certainly attempt to do it yourself just to get some information about what might be happening, okay? So what we do is we lay on the side with our hips and knees at a 90-degree angle. Back is just basically flat when we're in this position. Now what we're going to do is we're going to take this leg and we're going to lift it up above the hip level, so my knee and my foot is above the level of my hip. I start to bring my leg back, and when I bring my leg back, my thigh should be in line with my body. Now if you had a hard time with the rectus femoris test and that was a positive test and you couldn't get that knee at a 90-degree angle, you're going to see it in this position. You're not going to be able to get that leg back behind you without your lower back starting to arch, which is why we oftentimes hold this opposite knee. As I let that descend down, can I do that? Can the knee drop below the level of the hip? Now this is a classic IT band test that if it can drop, then we're good to go. But the challenge with this is being able to see what's going on, which is why it needs to be done by a practitioner. But as an active test, if I bring my leg back and I let it descend, how far can it go down? And in this position, I can go pretty much all the way down to the table with the leg fairly in line with the body. So there is not shortness of the TFL and the IT band or restriction in the hip, okay? So I have control of it and I can bring it up and down. But as a self-assessment, if you go back and things are getting distorted, you're feeling your back arching, there's low back discomfort, you can't let the leg hang all the way down, or it goes partially down and it does this sort of thing or that thing, it's a positive test that there is going to be some probably shortness in the TFL muscle, and again, some positional issues within the hip itself, as I explained very thoroughly in that video that I'm going to attach, okay? But once we find during the hip flexor assessment that there's shortness in the psoas and the rectus femoris, those are the priorities. But then we can also move on to this test as well. If those tests are negative, we don't find anything on those, or if we're seeing a lot of that veering off motion of the hip. Now, if you saw the opposite and the leg moves in toward the midline and rotates inward, usually that test is going to be negative, although we can find some interesting things on that test when we group them in together. But I wanted to bring it up because it's a very important thing to do, is to make sure we combine those hip flexor assessments with this side lying position to get an optimal evaluation of what's going on with the hip and its capabilities to move. All right, so one additional finding that I want to talk about, because I'm sure I'm going to get asked about this, what happens if the reverse occurs? So that as somebody lowers their leg below the level of the table, and instead of the leg moving out to the side and abducting, moving away from the midline, what if it rotates in and moves into the midline? This is very common with individuals who, number one, are hypermobile, or number two, by people that essentially when they were children sat like a W, so sat with the legs out to the side and watched television and so forth. So there's a lot of flexibility or range of motion, and the hip, for whatever reason, is preferentially wanting to move into a medial rotation position. Now with this, oftentimes we'll find is that there's resistance to external rotation. So there is oftentimes some degree of hip flexor shortness. The psoas may or may not be positive, so the leg can descend quite well, but there's certainly some challenges with the legs moving apart and laterally rotating. So there's a few structures to address there. So as you could tell, that there's a few things to look at here. As a psoas assessment is not just a psoas assessment. We really need to evaluate multiple things around the hip. Can we let the leg descend down into hip extension? And are we noticing features of excessive abduction and external rotation, or excessive adduction and internal rotation when we're doing that extension test? So when you follow these three principles or portions of this test, it can give you a lot more valuable information on what you might need to do and what you might need to address in order to optimize your hip function. All right, so that's it for this video. There is much more. I'm going to rely on a lot of the feedback and the comments that you guys have. So make sure if you like this video, give me a thumbs up. If it was helpful, comment down below any questions you might have. And of course, subscribe to the channel and hit that notification bell so that anytime new videos come up, you get notified immediately and you can check them out. So I look forward to seeing you on the next one. Thanks for watching.